Good evening, everyone. My name is Rona Wilk, and I'm the president of the class of 1991 and a member of the AABC Project Continuum Committee. And on behalf of both of those groups, it's my pleasure to welcome you all tonight to What to Expect When You're Expecting Menopause. This event came about because I realized as I entered menopause that despite being pretty educated and responsible about my healthcare, I really did not know what to expect at this juncture in my health life, besides the joy of not having to buy pads and deal with my period anymore. And no one had handed me a booklet about menopause like they did when I got my period, but like AARP, if you're out there listening, this is an opportunity. So we hope that tonight will be a sort of live action version of such a booklet. And I hope that you brought your questions for our amazing guests, because this is also about learning to be the best advocates that we can be for ourselves. One housekeeping note, this event is being recorded. Attendees will not have microphone or camera access during this online event. Attendees' voices, likenesses, and/or images will not be captured by Barnard College, and written submission of questions may be shared during the Q&A portion of the event. Now, it's my pleasure to introduce Dr. Marina Catallozzi, Barnard's Vice President of Health and Wellness and Chief Health Officer. Dr. Catallozzi is board certified in both pediatrics and adolescent medicine and is an expert in qualitative methods and education science. She has an active adolescent medicine practice in Washington Heights and is currently an associate professor of pediatrics at Columbia's Vagelos College of Physicians and Surgeons, where she has served as the pediatric clerkship director and medical education scholarly project track director. She's also an associate professor of population and family health at the Mailman School of Public Health, where she has served as director of the General Public Health Program, co-lead of the Sexual and Reproductive Health Certificate, and the faculty in Mailman's core curriculum. Over to you, Dr. Catallozzi.
Thank you so much, Rona, for that kind of introduction. And I am just so pleased to be here tonight in our What to Expect When You're Expecting Menopause. And this is a presentation of the Alumni Association of Barnard College's Project Continuum, the class of 1991, which is right about the right time to be thinking about menopause, and the Francine A. LeFrak Foundation Center for Wellbeing. As Barnard's inaugural Vice President for Health and Wellness and Chief Health Officer, my work at Barnard really centers on supporting the health and wellness of all members of the Barnard community, and that certainly is inclusive of alumni. An important part of my work is overseeing the creation of the Francine A. LeFrak Foundation Center for Wellbeing, which will be a dedicated space that supports physical, mental, and financial wellness. And it's going to be housed at the heart of campus in the former LeFrak Gymnasium in Barnard Hall. It's scheduled to open in early 2024. We are so enormously grateful to the extraordinary generosity of Barnard trustee Francine A. LeFrak and the Francine A. LeFrak Foundation for making the center possible. And it's going to bring health and wellness in all of its dimensions to the center of Barnard's campus. We'll have a state-of-the-art 4,000 square foot fitness center, a mental health suite offering mindfulness, community gatherings, and other wellness programming, and an innovative financial well-being suite to provide programming for financial literacy for our students and financial planning for our staff and faculty. We look forward to the LeFrak Center being a national model for campus wellness and for community wellness as well. And in that community, of course, we think of our alum. To the alumni here tonight, I'm also really pleased to share that we'll also be converting the former pool in the lower level. I know that this is something that lots of people think about when they were here at Barnard in their time with the pool. And that's going to become a 225-seat multi-purpose theater, classroom, rehearsal, and presentation space. We're also renovating the mezzanine level, adding a lounge for women athletes, an alcohol and substance awareness counseling space, a low stimulation room, and a brand new locker room. We'll also be adding a healthy food option in the lobby of Barnard Hall. We very much look forward to welcoming all of you back to campus to show you the LeFrak Center when it's up and running next year. And now it is my absolute pleasure to introduce you to tonight's very special guest and current Barnard parent, Dr. Anna Barbieri. Dr. Barbieri is a board-certified gynecologist, integrative medicine physician, and a specialist in menopause certified by the North American Menopause Society. She practices at Mount Sinai, New York City. She provides personalized, modern holistic menopause-related care, and she's also the founding physician of Electra Health, a digital menopause education company. You all know there's been a recent uptick in media coverage of menopause, including a February 2023 cover story in the New York Times Magazine that was entitled, "Women Have Been Misled About Menopause." I think we can all agree that menopause is having a moment. Barnard is so fortunate to have Dr. Barbieri here with us tonight, and I'm sure we'll all learn something as Dr. Barbieri helps to demystify the menopause experience and advise on how to best advocate for yourself with your healthcare provider. And I have to say that Dr. Barbieri actually, in her prior career, when she was doing obstetrics, delivered my child. And so she has a very special place in my heart. And we are just so excited to welcome you. Thank you so much for this presentation, and we cannot wait to hear from you.
Thank you so much, Dr. Catallozzi and the whole Barnard team here. And thank you all for attending tonight or listening later. I am here not just as a physician and a menopause specialist and an ex-obstetrician, but I am also here as a proud Barnard mom. And I have to say, when my daughter and she just finished her freshman year, which went great. When she and I were looking at schools last year, she and I walked onto the Barnard campus, which was just a stop on our way for a sort of looking at colleges weekend. And within 10 minutes, she turned to me and said, "You know what, this is where I belong. And this is where I want to be." So it's really doubly special for me to be here tonight. So hello, everyone. So, and thank you, Dr. Catallozzi, for that generous introduction as well. My name is Anna Barbieri. I am a menopause specialist, an OBGYN, and integrative medicine physician. And I really, in my professional life, focus now on both the care of women in midlife, especially across the transition of perimenopause to menopause. I have teaching responsibilities, and I also focus on advocacy for this age group. And part of my professional life, and I'll spend a minute on that a little bit later, is really trying to advance awareness of menopause, in self-education about menopause, self-care in menopause at scale through my work with Electra Health. So today I wanted to spend a little bit of time just giving you sort of the lay of the land, going over some terms, taking you through some of the common experiences along this transition, showing you and sharing some of the sort of basic interventions that we can use to feel better, sharing with you some of my philosophy around perimenopause and menopause, and then speaking a little bit about how you can access care to feel better and thrive through this change. And hopefully we won't spend too much time on the slides. I don't have a lot, although I do have to warn you, I could talk about this topic probably for 3 weeks straight. So I'll try to be brief, and there's a lot to cover. But at least this will be somewhat of an interview. I'll start by saying that, until about 7 or 8 years ago, I, as an OBGYN physician herself, did not know much about perimenopause and menopause. I came of age in residency in the early 2000s. I finished my OBGYN training in 2003, right on the heels of a study that came out in 2002, looking at the risks and benefits of hormone therapy at that time. A study that claimed that hormone therapy really gave women increased risk of breast cancer, and was such a change in practice that literally overnight menopause just sort of disappeared from the curriculum, and a lot of both providers but also women just decided nothing could be done. So I actually did not have much training when I was in my training on this topic. And when I got to my own experience of perimenopause, which started on the earlier side for me, really 40, 41 or so, and it started with experiences of some lack of focus and even forgetting words, I literally thought I had a brain tumor. I took myself to a neurologist. I had a brain MRI. It was fortunately negative. And it took me a while to figure out what was happening. And it wasn't for a few months until this light bulb went off when I tried to search for what was happening, until I figured it out. And then that started me kind of on the path of changing my career and really focusing on the care of women in midlife and beyond. And I think finally, our age group is sort of having its moment as we move away from kind of focusing on fertility and contraception, and those are extremely obviously important topics, but I think it's finally time to shed some light and pay attention to this important age group and our health beyond that. So I'll start sharing my slides. Let me just get to them and hopefully hope everyone can see it. So I sort of titled my talk for you today, Menopause Thriving in Our Second Spring. And we'll talk a lot about the symptoms of perimenopause and menopause and its consequences. And a lot of it is going to sound really negative. And I do think that menopause has kind of a bad rap, right? Like we think of it as getting older, getting sicker, having to fix a lot of these symptoms. Some of it comes from the physiology of perimenopause and menopause and the symptoms we encounter, but I do think some of it is sort of our cultural and social perception of menopause. And I am kind of on this really personal mission of reframing this. Menopause in other cultures actually means something else. For example, in Southeast Asia and China especially, menopause is known as this time of a second spring. And if you think of spring, it's really time of renewal, new growth, new space, and sort of entering kind of a new phase. So I do want to speak a little bit on that because I think we can reframe kind of this change in a more positive light. That's not to say that there aren't interventions that we don't need to reach for in order to feel better, but really we can kind of start understanding menopause in a more positive way. It's obviously a universal experience. As long as we live long enough, all of us will go through it. And it's certainly not an illness. It's a natural transition, just like puberty or pregnancy. There are some exceptions to it. And for example, some women go through surgical menopause or premature menopause. Those are a little bit different, but in the end, the experience of menopause is universal. It can be very individual in how we handle it, but the process itself, the experience itself is universal. Before we get into it, I wanted to also cover a little bit in terms of nomenclature or terminology of menopause, just so we're all on the same page. Menopause is really a moment in time. It means the time of our last period or cessation or stopping of menstruation. However, everything however, we're not in menopause or we're not postmenopausal until a full year has gone by from that last period. And I think people are sometimes, it's pretty confusing to see these terms. So really, when you'll hear me talk, being in menopause or postmenopausal means a whole year has gone by since that last period. Being in perimenopause means we're along the transition between sort of regular fluctuations of our hormones, and we'll get into that here, until that 1 year past the menstrual period. And the period of perimenopause, which by the way can be as long as 10 to 12 years, tends to be that rocky time, sort of just like puberty can sometimes be a rocky time, and having two teenagers around, I can certainly attest to that personally. So perimenopause is everything from when our hormones first start changing through that 1 year past the last menstrual period, and post-menopause, or we are in menopause, or we are menopausal, means everything from 1 year past the last menstrual period on. So what exactly happens in perimenopause and to menopause? Well, these changes are brought about by changes in our hormones. Hormones really being substances that are made in one part of the body, but can have an effect on other parts. The three main sex hormones for women are estrogen, progesterone, and testosterone. But we certainly have a lot of other hormones, and we tend to forget sometimes about them. You know, we talk about estrogen therapy and progesterone therapy and testosterone, but we have to remember that hormones don't exist in a vacuum. Everything works together. Everything is interconnected. We have about 40 different hormones in our bodies: thyroid hormone, cortisol or the stress hormone, insulin that regulates our blood sugar. These are all examples of hormones, and they certainly work together with our sex hormones as well. For the purposes of this presentation, we'll really focus on the sex hormones and what happens to them. So this is kind of a very easy graph to follow. It looks really at the fluctuation of the main sex hormone, female sex hormone, that is estrogen, all the way from childhood through the time of being in menopause or postmenopausal. And as you can see, this hormone, along with its sort of sister hormone, progesterone, stays pretty stable and low. It goes through a little bit of upheaval in puberty. Through our sort of premenopausal or childbearing years, these hormones remain pretty stable. They do change during each menstrual cycle and follow a very predictable pattern of rising and falling, but cycle to cycle, typically they stay relatively the same until we enter this super rocky part of perimenopause. That typically starts sometime in our 40s, but can start a little bit earlier for some. And typically these levels fall around the time of menopause, and 1 year after they are kind of lower and are more stable. And I just wanted to let you know that these ages here on this slide are very approximate. There's a lot of exceptions to that. There is about 5% of women who have their last period by age of 45. That's called early menopause. There's about 1% of women that have their last period prior to the age of 40. That's called premature menopause. And of course, as we mentioned before, some women undergo surgical menopause at any age at which ovaries are removed, or have medically induced menopause through various treatments, including certain hormonal treatments and, for example, certain cancer treatments as well. How can I advance this? Let's see. Oh, sorry about that. So what exactly happens in perimenopause when we enter this rocky period? So for many women, this is a time where certain symptoms arise, and they are actually different from what we classically think the symptoms of menopause are. So we hear a lot about hot flashes, night sweats, vaginal dryness. That is not how perimenopause starts for most. Perimenopause, it's this time when our hormones go from the super orderly sort of monthly transitions from one to the next, and everything gets a little bit wacky. So instead of this hormonal harmony, so to speak, that you see on one side of the slide, I mean, it seems like the band is just not all together. For most, and again, this is a very individual experience, but for most women, early perimenopause is going to carry with it more irregular menstrual cycles and bleeding actually closer together than skipping periods. Bleeding may be heavier. There can be more PMS, both physical and emotional. There can be breast tenderness. There can be a little bit of night sweats, typically right before a period and during your period, and sleep disruption of the type where, I don't know if any of you have experienced this. I certainly have. Waking up at the same time every single morning at 3:11 a.m. That was my time to wake up. That is often accompanied by sort of a heightened sense of anxiety. Some of my patients describe it as sort of dread over stuff that, you know, you may have done the same way for 20 years before, and all of a sudden it's somehow stressful. And sometimes weight gain accompanies this as well. And that's often sort of not understood very well. And this is the time when a lot of women go through a variety of different medical appointments. They're trying to search for the answer. And your gynecologist may say, oh, no, this is not menopause. You have regular periods, nothing to do with that. You're only 42, you're only 44. It's not time for that yet. But this is that very initial phase. This is not a phase of low estrogen, actually. This is a phase where Estrogen may really go up and down and sometimes be even higher than it was before, but this phase is characterized by low progesterone. And we use certain interventions for this phase specifically that may be different from the later phases of perimenopause when estrogen levels start to go down. And this is when we encounter kind of those more classic symptoms: hot flashes, night sweats, periods that are spacing out, so they are not coming every month. There could be, 3 months between, 6 months between, skin gets drier, hair starts to kind of get thinner, and sleep can get even worse. Some women experience more depressive symptoms during this time. The brain fog becomes even more kind of pronounced. Difficulty with concentration, forgetting words, for example, things like that. And it's really, and this experience, even though it's so universal, and even though some people get really lucky and don't really feel much of it, can impact some in really profound ways. I'm always, I see patients in perimenopause pretty much every day in my gynecology office, and I will hear things like, "I've lost my light. I don't think I can do my job very well anymore, and I love my job." Or I'm afraid to speak up at that board meeting because I don't think my brain is working right, and I'm afraid of how I'm not going to be able to perform, or I just can't keep it together anymore. So I think it is an important transition to pay attention to. And I think we as women who will go through it, have gone through it, or are going through it, we need to understand why it happens and what we can do. This is just a short list of things that can happen. And I'm going to try to, even though there's so many things on this slide, there's something like 34 different signs and symptoms of menopause. I still want to go back to my positive message on this transition. Many of these things are transient. Many of them go away on their own. Some of them may be more long-term and persistent. And that is, yet another reason why we really need to take charge of our health, especially during this time. These are just some statistics on the impact of menopause because of the symptoms that it can bring. So many, so many of us are going through this right now. 80% of us will have significant symptoms, including hot flashes and night sweats. Those are what those vasomotor symptoms are. Some, even women who don't have those classic symptoms, many of them will be really impacted. Such an effect on sleep, such an effect on mood. Our risk of cardiovascular disease is going up. Our risk for osteoporosis and loss of bone, loss of muscle mass is going up. There's really interesting research going on right now. There's if you'd like to check out her work, she's a researcher, a PhD at Weill Cornell here in New York. Lisa Mosconi is really looking at a lot of studies linking the transition of perimenopause into menopause and cognitive or brain function, showing that actually our brain metabolism can go down by up as much as 20% during this transition, and how we can protect our brain health. This in turn has impact on our work, on our relationships, on our general happiness. So it's really, I think the time is right to finally address it and learn how to address it both ourselves, how to advocate for ourselves, and how to get the treatments and interventions we need. There is a lot of, and we could talk again, I could talk probably for 6 weeks about the different interventions for symptoms of perimenopause and menopause. We, of course, can't really stop it, but there are many, many different things that we can reach for in order to feel better during this transition. As not just a gynecologist, but as an integrative medicine physician, I do want to say that, the foundations are always important, as always apply. Foundations of nutrition, of sleep, stress management, of movement, of utilizing mind and body techniques, are really foundational. That's what we really, I mean, most of our health is really that. So whether it's having adequate time for sleep, engaging in movement pretty much every day, whatever it is that you'd like to do, it's better than doing nothing. Although things like strength training and exercises that impact our muscle mass are very, very important, both for prevention of bone loss, building up muscle mass, maintaining a good metabolic rate, and so on. Nutrition is very important. Unfortunately, we just don't know. We're not at a point yet where we can say, you know what, this is the perfect diet for you or for me. Certainly the data shows that a diet that's really lower in refined foods, refined carbohydrates, lower in sugar and processed foods, and a diet that really focuses on a hefty dose of protein, moderate in fat, and lower in those refined carbohydrates tends to be better for women in this phase of life in terms of weight maintenance, quality of life, and even weight loss. There are a number of different supplements and over-the-counter treatments. I do have to caution you, even though, again, as someone in integrative medicine, I do deal with supplements quite a bit, and I do believe in their value when they are chosen well. There are many companies that will really, whose marketing and packaging is better than the ingredients inside. So we do need to be really careful about how we choose our supplements and be smart about how much money we spend on them, how many of them we're taking, and what we are taking them for. To me, supplements are very similar to medications. They can carry side effects, they can cross-react or react with other things we're taking, and they need to be taken for a purpose. I put two of my favorite ones here. Magnesium. Magnesium comes in different types. There are different types that are suited for something like constipation versus sleep. But magnesium is a pretty harmless supplement when it comes to potential harm. And I often will recommend it as sort of a first line intervention, for example, for something like sleep. Ashwagandha is another one. Ashwagandha comes to us from the Ayurvedic tradition. It is a very well-researched agent. There's a lot of studies on it, looking at both sleep quality as well as reduction in vasomotor symptoms, so hot flashes and night sweats. So that's sort of another one to go to. And there's a number of different ones. And again, we could have a whole different presentation about that. Hormone therapy is a big one. I'm going to spend 2 minutes. Actually, let me do medications first. There are non-hormonal medications that, as a side effect, will help with some of the symptoms of this transition. The choices there are going to be really certain antidepressants, especially things like venlafaxine, which is Effexor. Some people also use, for example, sertraline, which is Zoloft, Wellbutrin even, gabapentin. This is really a medication for sleep and chronic pain that also will reduce hot flashes and night sweats. There's also a new kid on the block, and we're all waiting for its potential FDA approval this month. Fezolinetant, we don't know what it's going to be called yet. It's supposed to get approved this month. This is a non-hormonal agent that really acts on the brain to reduce hot flashes, night sweats, and may improve insomnia. And the reason certainly I'm waiting for it, I do have a lot of patients who have or had breast cancer who may not be candidates for hormone therapy, and this would be a really good tool for them. So finally, hormone therapy. This is a big one. The pendulum is swinging back. We're using a lot more of it now. Back in the 90s, my favorite decade, lots of women were on hormone therapy, about 30% at that time, and those prescriptions went down by almost 86% after that study I mentioned in 2002. The use of hormone therapy is now on the upswing because we do have fresher data about the side effect profile and risks and benefits of hormone therapy. Currently, even our very conservative society, so North American Menopause Society, International Menopause Society, American College of OBGYN, are on board with hormone therapy for most women that are at average risk and healthy around the time of menopause. The standard in hormone therapy really now should be bioidentical hormone therapy. What does that really mean? Hormones that we're using are in the same structure or have the same molecular structure as human hormones. That study from 20 years ago actually used Premarin. They were equine estrogens, meaning hormones derived from pregnant horses, and synthetic progestins. The current new standard and the data suggests that it's actually safer to use, no surprise, human versions of hormone therapy. It's a medical intervention. The benefits versus risk calculation seems to be best in favor of hormone therapy when we started pretty early. So around the time of menopause, that last period, but no later than 10 years after, and best to start it within that 5-year window. You're looking here at short-term benefits: better sleep, less hot flashes, night sweats, often better mood, reduction in vaginal dryness, improvement in skin elasticity, potentially also longer term, slight reduction in the risk for diabetes, some cardiovascular protection, and reduction in the risk of osteoporosis. And again, I'm really excited about the data that's going to come out regarding cognitive function and hormone use. There are risks to hormone therapy. The traditional risk of strokes, blood clots, and so on. Like if you've ever seen that insert from hormones or a birth control pill, that's always going to be there. That does not seem to be the case based on the data we now have on bioidentical hormones, and especially estrogen that's delivered through the skin. So certainly when I start people on it, it's always going to be transdermal bioidentical estradiol therapy with additional progesterone therapy. There's a lot of nuance there. Some women don't need progesterone. Some women need a different formulation. There's that conversation about risk and benefits is really nuanced. It's going to depend on someone's preferences, philosophy, medical history, family history, understanding of the risks, especially when it comes to breast cancer. And we still talk about that, although the breast cancer risk as calculated in that study from 20 years ago that changed everything seems to be an overestimate of breast cancer risk with hormones, but it is something that we need to mention. So when I start somebody on it, we literally sit down and go through everybody's personal risk and try to apply this to them to make a shared decision on this therapy. I also want to say that estrogen and progesterone therapy can be started early if someone has undergone surgical menopause. It's actually recommended in that case because of its long-term health benefits in that group. So hormone therapy, one other word about it. We mentioned the word bioidentical, that means in the human form, versus non-bioidentical, meaning hormones that are not in the human form, but some of them are still in use, and they will bind to the receptors for those hormones in our bodies, although slightly differently. Another sort of differentiator there is compounded hormones, so hormones made by a specialty pharmacy to order, versus FDA-approved hormones, so hormones we can write for as a prescription that you can get from your local CVS, for example. There is an advantage to FDA-approved hormones in terms of their consistency and safety and reliability versus compounded hormones that, again, are made in usually a smaller facility. So, my philosophy is that if we have access to safer products that are right for us, we should go with them. FDA-approved hormones will typically be It's a whole other topic. Let's not get started on insurance coverage for some of these things, but FDA-approved products will typically be covered at a higher rate than compounded products that usually are not covered. So for all of those reasons, I usually start my patients on FDA approved formulations. But I do think that there are some individuals that require slightly different formulations and something that's much more customized. And I sometimes will go to compounded hormones if need be, using very, very specific compounding pharmacies that have met certain safety and review criteria there. Testosterone therapy, I don't think we have time for that today. That's a topic for I think another conversation maybe. Testosterone therapy is typically used for purposes of sexual health. Unfortunately, there's no FDA-approved version for women for testosterone, even though there is a recognized guideline on its use. So for testosterone therapy, we typically do use compounded testosterone, or we stop using, literally telling patients to use 1/10 of the regular version, which I don't think is very precise there. And I'm sure I would welcome questions on this. There's always a lot of questions on hormone therapy. And I think what I would love for you to take away from it is I think we should all be aware of this tool. We should be able to ask our providers about it and not accept a non-nuanced and extremely simplistic answer on this topic. This is a complex topic that requires time and understanding. And when you hear somebody say, oh, don't do it, it just gives you cancer, or everybody should be on hormones, that's not, those are extremes. And the reality is that we are individuals, our needs are individual, we respond, our risk benefit ratio will be individual. It's really a very careful individual discussion. The easier sort of decision is really when we talk about hormones that are only related to vaginal and bladder health. Those are going to be your topical vaginal hormones. So vaginal estrogen, something called vaginal DHEA, they are really used for purposes of reducing vaginal dryness, painful sex, and recurrent bladder infections that we can also get into in menopause. Those are very, very low doses of these hormones. They are not absorbed systemically. They don't really circulate, and we use them really frequently without getting into all of those risks and benefits like we do with systemic hormone therapy. So where do we go from here? So that's sort of the presentation there. Hopefully we have time for some questions. I do want to let everyone know, I really think it's important for us to be able to access good midlife and menopause care. Unfortunately, I just read this statistic, something like only 6% of surveyed physicians feel comfortable discussing this topic. So how the heck do we go about finding somebody? And I'll share a tool with you. I am a menopause specialist and I am fascinated by this topic. I love it, but I actually think that every primary care, internal medicine, gynecology, endocrinology physician should be familiar with it. I mean, come on, this is like being a urologist and not treating the kidneys. Like we got to change that. One of the ways you can access better care is one, by finding people who are trained in this area and are knowledgeable in this area. A good resource for that will be the North American Menopause Society. The website for that is menopause.org, and you just plug in your zip code and you can find the people around you that are certified in it. Another way to access better care is knowing how to identify the right information online about it. And there is just so much stuff out there, and there's so much confusing stuff, and some of the stuff is not really valid and maybe even not very safe. So here I'm going to give my digital company that I work for a plug. So we're Electra Health, and we're proud to kind of present really evidence-based information on perimenopause and menopause through this integrative, more holistic lens. And certainly if you go to, again, NAMS or American College of OBGYN, you're going to be able to find that information there as well. I think even reading some of those materials and prior to going to meet with your provider is already going to help you get through that visit. The reality is most of the interactions with the healthcare system, we have like 10 minutes for that. Impossible to cover this. I mean, I've been talking for, I think, 30 something minutes here already. Impossible to do that in that amount of time. So it's very helpful to go in informed and go in with a certain basic knowledge about it to be able to ask questions and not be afraid of asking questions. I see patients all the time who tell me, I was dismissed. I wasn't even allowed to ask it. Like, that's not how we need to do healthcare. Like, we have to get past the point of I told you so. Really asking, I'm experiencing this. Could this be perimenopause? Could this be menopause? Could this be something else? How do we know it's not something else? Do I need to do any lab work? Do I need to, what options do I have? Is hormones something I could get into? Why and why not? What are the risks and benefits to me? So really, really, let's all speak up on this topic, because this is the point in our lives where we got to take charge. These changes may impact us for the next 10, 20, 30 years. So now is the time. Let's get to questions, because again, I could talk forever, and let's not do that.
Well, I was going to say, I think hopefully here's where being Barnard women comes in handy, and we can be assertive in our advocacy for ourselves. So first of all, someone asked also if you can put up the slide of the different symptoms again, or if we can send it around if you feel comfortable doing that. But I think people are taken aback a little bit with how many things are. Yes, probably this one, because I know I had things that I did not expect, including joint pain, and it's been a journey to figure out that.
Joint pain is, I see it very commonly, and we actually see an uptick in autoimmune disorders in this age group too. So interesting, very interesting. And one of these things here is volatile emotions. Okay, I want to make a distinction there that while perimenopause and menopause can affect our emotional regulation, sometimes that emotional dysregulation is well-deserved. So when I get home and I got to do everything at home and everybody is just relaxing, that's not perimenopause. That's people not, pitching in. So don't, let's not excuse certain behaviors just because we're going through this change.
Exactly. So I guess we have a bunch of questions sort of related to hormone replacement. In one case, someone is having a radical hysterectomy and is on HRT and wants to know kind of the timing of, when it's a medical, I guess what you would call medical menopause. Like, do the symptoms get worse? Do they stay the same?
So if someone is undergoing this procedure, but they're already on HRT, symptoms may be slightly different, but they would not, this person would not go into menopause overnight unless HRT was stopped.
Okay.
So as long as it's medically appropriate for this person to remain on HRT, symptoms should remain the same, meaning well controlled with HRT, or that HRT may need a little bit of adjustment. When we take ovaries out, because when we're in menopause, ovarian level of estrogen, progesterone production is very low, but ovaries actually still make some testosterone. So removal of ovaries as part of a radical hysterectomy will drop someone's testosterone levels. So we may see sort of less energy, sexual health, libido getting affected from that. But it should be, when you're on HRT now, that change will be more subtle compared to somebody not on HRT and getting a radical hysterectomy with ovarian removal.
Right. A lot of people seem to be asking, like people have either had conversations with their doctors and it seemed very simplistic, but clearly it's not. And have been asking also about, can you do testing? Some people recommend getting tested, but then are you fluctuating as you're being tested? And so maybe it's not accurate.
Yeah.
Can you talk a little bit more about kind of how to approach the idea of HRT and, the risk factor more or less than birth control?
So, if I can say 3 words about testing. So a lot of people come in and want their hormones tested, right? So it's useful to a point because in perimenopause, remember that graph with all the things fluctuating? In perimenopause, hormones are going to fluctuate a lot, especially estrogen and progesterone. So whatever result we get today, it will be different tomorrow. It was different a week ago. So the usefulness or utility of hormone testing in perimenopause is very limited, just because they change so much. So I typically will go by symptoms more than hormone levels, but where testing for me and my patient comes in perimenopause is by making sure that it is not something else. So someone with hair loss, weight gain, fatigue, for example, we're going to look at your thyroid levels, your B12 levels. Someone with weight gain, sure, we're going to look at your blood glucose, at your A1C, to look at your sort of cardiometabolic profile. So testing may be useful to exclude some things that we may think it is in order to kind of land on perimenopause. Testing in menopause itself is not that useful unless we are looking at testosterone levels, because we know that symptoms of especially low estrogen in menopause already, that estrogen level is going to be low. So I hope that sort of covers testing. There's also functional hormonal testing, which I think gets complicated, and that's another topic for a whole other
have to do part 2 of this seminar. People are asking about bones and bone density and osteoporosis, and also there's a question about what can we do preemptively before heading into perimenopause, or when you're in perimenopause versus actually in menopause, postmenopausal, to kind of reduce the risks, especially with bone density. And someone asked, what about bone density or osteoporosis, once you're already in menopause, and can you do anything to alleviate?
For sure. Yes. So I think, and this comes down to those like sort of foundational health behaviors that I mentioned: nutrition, movement, sleep, relationships, stress reduction. I think that's extremely important. In fact, when I have patients coming in who ask me for hormones directly, often I will say, no, let's do your evaluation. Let's make sure it's not something else. And for the next 10 days, we can do anything for 10 days. Let's look at how your body will respond to a different diet, to a different schedule, to a different level of self-care and self-compassion. And then we'll start from there. Let's see how your body responds to something like not drinking alcohol or really reducing alcohol. Such a tremendous effect of that. So for those of you who can't sleep and really like red wine, switch to white, dry, or forget it altogether, and then see how you're sleeping. Your sleep will get better. We really don't process alcohol the same way. So I think as we enter perimenopause, there are three things that are important. One, really getting into the habit of maintaining those healthy behaviors. Whole food, lower sugar, lower processed food diet, adequate sleep, adequate time for ourselves, movement, all of that. Then comes risk assessment. Talk to your family members. What was their course through this transition? Typically, our perimenopause experience is going to be very similar to our mother's perimenopause experience. What was that like? What do I need to learn about? How do I need to, what's going to come at me? Track your period. If you notice that that period is coming closer together, that you're getting more PMS, that you can't sleep that week before your period, that's early perimenopause. You're there. It may last for several years, but that's there already. Looking at assessment of things like breast cancer risk, your cardiometabolic health. What is your risk for diabetes? How are you tracking with that? You know, people do get sort of this annual blood work that's going to show you a trend towards, for example, insulin resistance or prediabetes. So being aware of that and already introducing some of these lifestyle interventions is going to go a long way. As far as easy things, certainly something like magnesium for sleep. Some women do great with ashwagandha. Some women, especially those of you who may be vegetarian or vegan, B12 deficiency can become really symptomatic. Supplementing with a multivitamin with adequate B12 it can be very helpful.
Okay, before we go any further, we're getting a lot of requests. So could you please spell out Electra, your health website,
Sure.
so that we'll put it in the chat or
ELEKTRA, Electra with a K, health. So what we're doing is that we're providing information, education. It's also an online sort of support system. So we have nurses who served as the menopause doulas for lifestyle change. We do telemedicine, but we also do, and this is that advocacy part, like we're now partnering with health plans and with employers to use menopause education, self-intervention, and visit preparedness to both on the employee level and to members of particular health plans.
Excellent. Just alumni relations, if you're listening, maybe we can include a link when we send out the recording of this event. All right, two very specific questions, but I'm curious too. Why is weight gain such a thing, even if you're eating healthily and exercising a lot? Which, okay, granted, I'm not eating so healthily, but still.
So it's like the weight issue in perimenopause, it's a perfect storm of a bunch of different things. One is hormonal change. As estrogen levels fluctuate, there is more tendency for our bodies to retain fat and deposit it in places where we did not have it before. So before perimenopause, most of us get, kind of fat deposition in our butts and thighs. During this time and after, it kind of travels to the abdomen. That starts a whole other process. So the fat around the abdomen, especially the fat around our organs, will make certain compounds or substances that are also active in a hormonal way. That then sets kind of this other thing in motion that's linked to insulin resistance and eventually prediabetes and diabetes. And it will also create inflammatory markers. That changes our metabolic pathways, and it becomes easier for our bodies to process energy we take in to process energy that we take in a way that makes it end up as fat and makes it harder for us to get rid of the fat we want to get rid of. Genetics is another one. So, and you look at women in generations above us, it's a big push too. And then finally, I have to say that lives we lead now, it's, lots of stress, lots of, constant obligations, not a lot of time for ourselves. Stress itself sets in motion certain hormonal pathways with cortisol that make that abdominal weight gain easier too. So aging, stress, hormonal changes in the nature of our food supply, decreased sort of mobility compared to times before, all of that.
And now we were not even supposed to have the wine to take out the edge off the stress, right? That seems unfair, Dr. Barbieri.
I did a while back. I did a talk on history of menopause treatments over time. So and I pulled I found this report from the mid 19th century where women used two things to feel better. So one thing was wine, and the other thing was cannabis. So
Oh,
not very different.
not very different. I thought you were going to say opium, but okay. Excellent. So I want to link the two questions, or sort of several questions. Nicole asks, does thinning hair improve as menopause goes on, i.e. do your hormones balance and does the hair start to adjust? And we've had a few questions about people who are postmenopausal, and can symptoms still be treated or, reversed, like maybe it's not quite the right word, but like what can we do once we've pushed through the actual menopause, perimenopause stage, and hopefully with our hair intact?
Yeah, hair is complicated too, because this hormonal transition is just part of the story. There is a lot of other issues at play, including things like stress, including things like genetics, and also certain levels of certain genetic propensity to for our hair follicles and their sensitivity to a specific hormone called DHT. DHT is a hormone that is made by DHT is created through a conversion from testosterone, and after menopause we actually have relatively more testosterone compared to estrogen. And depending on how sensitive our receptors are to that and how many of them we have in different places, we can experience this DHT related, it's called androgenetic alopecia, with hair loss. So it's complicated because for some women, hair loss kind of slows down once you are in menopause. For some, it continues, but it requires, if you're losing a lot of hair and it's thinning in perimenopause to menopause, once we're in menopause, it does not go back to what it was 20 years before.
Okay. And what about for women who are postmenopausal? Like, what kind of actions can they take to kind of keep living their best lives?
So it goes back to all of those behavioral foundations for sure. It also goes to certain, and I know we had some questions about osteoporosis, risk assessment for that, prevention. Actually, one of the best predictors of how healthy we're going to be and for how long is muscle strength and muscle function. So I cannot say enough about physical activity and exercise. And I know it's such a boring topic usually, but I can't say enough about it. Nutrition is just as important. I think taking care of our vaginal and bladder health, prevention of those recurrent UTIs, especially with topical estrogens, it's such a safe and simple intervention that's there. The question on hormone therapy, if somebody is still suffering from symptoms, very nuanced. There are some women who do sign on to it even after that window has elapsed, but that requires careful counseling also.
Right. Are there also, I mean, my doctor has suggested there are also homeopathic remedies, sort of botanicals that mimic estrogen that are safer than.
It depends on what we need them for. There are some that seem to be quite effective. Nothing is as effective or as straightforward sort of and efficient in reducing symptoms as hormone therapy, but there are some botanicals. One of the safest ones are going to be something called soy isoflavones. This is not soy, these are substances derived from soy that are phytoestrogens. The data on some other ones, like black cohosh, for example, is not as clear. I typically, if we need to use botanicals, we'll do soy isoflavones or something called ER731. That's a phytoestrogen also. So, and there are some non-hormonal botanicals as well. So Swedish flower pollen, for example, that goes by the commercial name of Relizen. And I just want to put a disclaimer, I don't have any financial relationships with any of these companies or any of the makers of these products, but Relizen is frequently used, especially for women at high risk for breast cancer or breast cancer patients.
Okay, I think we have time for one more question. And let's use it for the advocacy part of when do you recommend getting screened for bone density, or do you recommend getting screened for bone density, and maybe in terms of starting to take calcium supplements or vitamin D supplements and that sort of proactive activity?
Great question. And full disclosure, I'm going to depart from official medical guidelines on this and give you my personal opinion. So the official guideline is that we start bone density testing at 65 unless someone has risk factors. And those risk factors may be previous osteoporotic fracture, family history of osteoporosis, thin frame, smoking, steroid use, things like that. The interesting thing is that one of the indications for hormone therapy around the time of menopause is decreased bone density. Well, how are we going to know that if we're not looking for it until 65? So again, this is a departure from the ACOG sort of professional, the sort of by the book checkbox guidelines, but especially with my patients with risk factors, but really for anyone, I do order baseline bone densities around the time of menopause, and we use that information to make an informed decision about whether to get into hormone therapy or not, because that can help skew it in a certain direction. So bone density, again, exercise, weight-bearing exercise, weightlifting, very, very important. We worried with osteoporosis about breaking our hips because of complications and morbidity and mortality that goes up around that. We will have less broken hips if we function better, if our balance is better, if strength is better. So I'm going to bang the drum on that. Calcium for women through menopause, about 1,000 to 1,200 milligrams. It's better to get that from nutritional sources. When we take calcium supplements, we can only absorb about 500 at a time anyway. And too much of calcium as a supplement can be linked to cardiac calcium deposits, vascular deposits, and kidney stones. So we have to be pretty judicious with that. Vitamin D is essential. It's best for us to get it from sunlight. That's how we make it. But if we need a supplement, then vitamin D3 for typical use, it's going to be, 1 to 2,000 IUs. I do test for it in my patients because there is such a thing as optimal levels of vitamin D. So when I do a kind of a more whole person 360 health assessment, that is part of it. And then we talk about vitamin D, sun exposure, and potential vitamin D supplementation as well. Vitamin K is important for vitamin D absorption. So if you're someone who's been recommended to take more than 2,000 international units of vitamin D, then vitamin K should be taken with it. And there are some supplements, a company called Life Extension, for example, makes a really accessible and inexpensive type of higher dose vitamin D plus K supplements.
All right. Well, you heard it here, everyone. I think if you take down your slide, we can say a proper thank you and goodbye to you. This has been amazing, and we thank you so much for sharing your expertise and your knowledge with us. And I think the key takeaway is ask questions, keep talking to one another. I know just even in talking to my friends, they've said, oh yeah, I had that symptom, or I was diagnosed with this. So it needs to come out of the shadows. It needs to just be a normal part of conversation about our health. And I hope that maybe we can get you back for a part 2 at some point, because it seems like people have so many more questions and are so eager to hear the answer.
I mean, these are great questions. I wish we had more time. Maybe we can do it again. I'd be happy to answer them.
I would love that, and I suspect that most people on this call would love that as well. So, and a thumbs up from Marina. So, thank you so much, everyone, for attending. There will be a recording of this. We'll send it out in an email. Like I say, hopefully we can also include Anna's company's email, web address. And we hope that you'll join us for more events like this as we move forward. So thank you, everyone. Have a great night. Thank you to Marina. Thank you to Anna. and to Alumni Affairs for helping to organize this. Stay well, stay healthy, and we will see you all soon. Thank you.
Thank you.